Hello everybody. Today I'm going to be discussing the NATA Position Statement on preventing and managing sport-related dental and oral injuries. So a few objectives for this position statement. The first is to give the athletic trainers the gold standard when managing acute dental injuries and making return to play decisions. Another thing the position statement goes over is the anatomy of the mouth to better understand injuries, dental and oral injuries. Another objective is to inform the athletic trainer on mouthguard effectiveness, as well as provide the athletic trainer with resources to reference when they encounter dental and oral injury. So a few terms that are important listed in the position statement. The first is buccal, which means closest to the cheek. Lingual means closest to the tongue. Labial means closest to the lip. And also to better understand the injuries that are listed in the position statement, they are named by the layer of tooth that is injured. So the most lingual part of the tooth is the enamel, then it's the dentin, deeper it's the pulp, and these are all portions of the crown. So the crown is the portion of the tooth that you can see, and the root is the portion of the tooth that you cannot see. Another structure that is very important when discussing dental and oral injuries is the periodontal ligament, or the PDL. And this ligament is the structure that holds the tooth, specifically the root part of the tooth, to the gum. And this is also the structure that allows the teeth to move when somebody has braces. So those are the main terms discussed in the position statement. As far as other stats that are reported, they talk about non-mouthguard mandated sports like baseball, basketball, and soccer. These athletes encounter 3 to 38% of all sports-related orofacial injuries. And these sports also experience 1.6 to 1.9 times they're more likely to sustain an injury. Some of the resources listed in the position statement for athletic trainers to reference. The first one is provided through the Academy of Sport Dentistry, and it is the emergency treatment card. Another resource is provided by the International Association of Dental Traumatology, or the IADT, and this is a document titled Guidelines for the Evaluation and Management of Traumatic Dental Injuries. The third resource is a website put out by the IADT, and that is dentaltraumaguide.org. As far as some general recommendations for athletic trainers, the first is the athletic trainer should be familiar with the NATA position statement regarding emergency planning in athletics. The athletic trainer should have an oral health care specialist in their contacts in case of injury, in case they need immediate referral, if they need a resource that they need to reference, or if they need guidance when they're managing a dental injury. The athletic trainer should also carry a dental trauma pack in their sports medicine kit. The athletic trainer should also be able to identify basic signs and symptoms of acute dental injury. And a big point that is mentioned in the position statement is the fact that there is an overlap in the mechanism of injury with dental injury between dental injury and concussions. So if an athlete endures a dental injury, then concussion evaluations and protocols should be conducted. So now we're going to get into the injuries that are listed in the position statement. Again, they are titled based on the layer of the tooth that is injured. So starting with the least severe crown injuries and going into the most severe root injuries. The first injury is crown infractions. So this is actually a crack in the enamel, and it is a non-emergency injury, and the athlete can return to play with a mouth guard. This injury is a little bit difficult to identify because there's little to no pain associated with the injury. And in order to really see the crack in the enamel, you would have to put it under light. And this is because the way enamel is arranged, it's arranged in prison-like or almost like crystal-like form. So it's not just like flat layers of enamel or tissue. So under light, you're able to see the crack in the enamel. The next injury is an enamel-only crown fracture. So this is a little bit of a deeper crack, but only the enamel is involved. So this injury also is hard to detect because it causes relatively no pain. Again, it's a non-emergency and it presents as roughness on the labial part of the tooth, and the athlete can return to play with a mouth guard. The next injury is an enamel dentin crown fracture. So this injury must be referred within 24 hours and the athlete can return to play with a mouth guard if pain permits. The next is an enamel dentin pulp fracture. So this is an injury that goes deeper into the tooth, and there's two different categories for the enamel dentin pulp fracture. The first, if the signs and symptoms are limited to only sensitivity to thermal changes, air exposure, and pain during mastication, the athlete is able to return to play if their pain allows and with a mouth guard. The second is the signs and symptoms include focal hemorrhage within the yellow layer of the dentin and acute pain. So if there is blood, then it is an immediate referral to a trauma-ready dentist. What was mentioned in the position statement is that sometimes athletes aren't aware that maybe they have poor dental health, that the tooth that was fractured might have been due to poor dental health. So if you do not see hemorrhage from the dentin layer, so long that you see the yellow dentin layer, it is an immediate referral. In the first case with the enamel dentin fracture, where there's only sensitivity to thermal changes, air exposure, and pain during mastication, it is a referral within 24 hours, though they can return to play with a mouth guard. So thus far, all of these injuries mentioned are injuries to the crown. Now we're going to move into injuries of the root. So the apical 1/3 of the root fracture. This is often undetected because pain is also very minimal. The tooth mobility is extremely minimal, and the athlete can return to play with a mouth guard if their pain allows, if there is pain, and the referral can be delayed as long as 24 hours. The next injuries, two injuries actually, the middle 1/3 of the root fracture and the cervical 1/3 of the root fracture, these present very similarly. This is where the tooth may appear to be displaced and appear elongated. So in this situation, the athletic trainer it is recommended that the athletic trainer reposition the tooth, and once it is back in its position, the athlete should gently bite down on a sterile gauze to further stabilize the tooth. If the tooth is moderately loose, the athlete can return to play with a mouth guard if their pain allows. If the tooth is extremely loose, they cannot return to play. And in both situations, this is a referral within 24 hours. The next injury is lateral and extrusive luxations. So in the case of a luxation, if any fragments can be gathered, you must place those fragments in a baggie with liquids such as saline or low-fat milk and sent with the athlete to the dentist. So never store these tooth fragments in a dry fashion or in a paper towel. They must be in some type of salt liquid solution. So with these injuries, this is an immediate removal from activity and a referral to a trauma-ready dentist or emergency facility. And before you transport the athlete, make sure you have them gently bite down on a sterile gauze and be transported in that way. The next and most severe injury is tooth avulsions. So in this case, the tooth must be located and gently rinsed with saline or a salt solution for a maximum of 10 seconds. And if the athlete is alert and oriented, the tooth should be replanted. So avoid rubbing or scrubbing the tooth when you are rinsing it. It is optimal to replant the tooth within 5 minutes. And also remember to refrain from touching the root of the tooth. This is where the periodontal ligament lies, and you don't want to damage the periodontal ligament by scrubbing it, or even touching it could cause damage. So do not sterilize the tooth with any chemicals. And once you have replanted the tooth, have the athlete bite down on sterile gauze to further stabilize and immediately transport. In the event that you are unable to replant the tooth, you should store the tooth in a storage medium. It is most optimal to use Hank's balanced salt solution, but any salt liquid is acceptable, as well as low-fat milk. So those were the injuries discussed in the position statement. The position statement also goes on to mention mouthguard effectiveness. So research has shown that mouthguards are consistently effective against protecting against oral facial injuries. There has been previous research that tried to argue the fact that, or the idea that mouthguards could prevent concussions, but the NATA position on that is that it is not recommended for concussions, and the research suggesting it was good for preventing concussions is that it positions the mandible in such a way that can absorb more shock. But as mentioned, the NATA does not recommend that stance. And it goes on to say that properly fitted, customized mouthguards are optimal when preventing oral facial injuries, and that mouthguards are effective for use with aerobic and anaerobic sports. Something else that the position statement mentions that's also extremely important is the need to have a team dentist or have some type of dental healthcare specialist in your contacts and on your sports medicine team, because dental injuries are very unexpected, and when they happen, you really want to have the best people on your side and have somebody available for referral, as a lot of these injuries must be referred within 24 hours and some of them are in an immediate referral. So you want to have optimal care for your athletes. It is in your best interest, and most importantly the best interest of the athlete, that you have that dental healthcare specialist in your contacts. So just to reiterate the objectives from the NATA position statement on dental and oral injuries, it was primarily to inform and educate the athletic trainer on the gold standard when managing dental and oral injuries, as well as provide the athletic trainer with some resources and guidance that they can reference in the event that they are encountering or caring for a dental oral injury. And the third is to discuss mouthguard effectiveness and fabrication and usage. Thank you.